So our third speaker of the evening will be Dr. Raphael. Dr. Raphael is the Section Chief for Academic General Pediatrics and the Associate Vice Chair for Community Health in the Department of Pediatrics at Baylor College of Medicine. His research is focused on improving systems of care for underserved and minority children with chronic conditions. His research is also complemented by policy efforts towards improving the care of vulnerable populations. So he is the founding director of the Center for Child Health Policy and Advocacy at Texas Children's Hospital. Nationally, Dr. Raphael serves as chair of the Public Policy and Advocacy Committee of the Academic Pediatric Association. He is a past appointee of the Lieutenant Governor to the Texas Health Disparities Task Force, and he has received the Meritorious Service Award from the Texas Health and Human Services Commission. So if we can welcome Dr. Raphael.
Okay, so for those of you who know me, I tend to be an optimist. I tend to be this person who says everything is possible, you can achieve anything. And so tonight I get to play the opposite role. So I'm going to be sort of the doomsday person who brings a dose of reality on Medicare for all. So I have to get into character now. So just give me a couple seconds. I'm there. And so I think it is a good thing to have this dose of reality because these are the questions that in debates that people are having right now. And so regardless of where you fall in terms of your opinions or thoughts about Medicare for all, it's important to understand what people on the other side are thinking. And so what I've tried to do is put this into three themes, or three thematic areas, in terms of understanding what the potential pitfalls are. So one is just overall healthcare financing, and then the next one is the demand side, and then the supply side is the third one, just sort of taking an economic approach to it. And some of these things have been covered already, so I'm not going to go into super detail on those and focus on the others. So the first one is just overall healthcare financing. And so we already talked about this. Ken pointed out this is that $32 trillion over the next 10 years. And this is just for federal government spending. This doesn't account for other national expenditures that will occur as well. So when we talk about these expenditures, this is just talking about what the federal government will input into this. This doesn't cover other kinds of expenditures as well. So just remember, this is just part of the piece. Overall spending. And then something that we typically look for in terms of trying to see what the impact of a specific legislation is going to have is a score from the Congressional Budget Office. So the Congressional Budget Office, I screwed that up, Congressional Budget Office is essentially a party-neutral organization within the federal government that tends to look at some legislation and then is able to give an impact score so you can understand if it's going to be beneficial, what's the financial impact overall. And from my understanding, that hasn't happened yet. So that's typically what the politicians wait for, and then they try to sort of play it either way to sort of spin it the way they want to, but it's hard to because that's sort of, when you set that, that's what sort of the lay of the land. So that's where we are with respect to overall expense. And then finance we talked about extensively already. So it's going to be lots of taxes. It's going to be taxes levied on the individual, and it's going to be much more obviously for people who have more wealth. So those who are over $250,000 per year in annual income, and then again, as Ken talked about, there will be this extreme wealth tax as well. And so I think the understanding is people who are low income to moderate income are not going to see much of a change in their taxes, but people who are on the wealthier side, actually people in this room, relatively are going to see those major increases. And then businesses and employers are also going to experience these taxes as well. So these are going to be payroll taxes. And in terms of the percentage of what those will be, some businesses say they will not be viable if they have to do this level of payroll tax. And so that's sort of both sides. So the employer side, the employee side, in terms of how people will experience this and how this will be financed. And still a lot of questions about other ways to finance it as well. And so now some of the theoretical issues. So some people say, well, this is going to be elimination of competition. So if you take all the private insurers out of the market, and now Medicare is setting the rate for, the government setting the rate for everything, there's this equal playing field. Well, it's that competition that really drives innovation, it drives new sort of technologies. And so if we get rid of that competition, what happens to all of that? And some people say there's all this data that shows how we came about with all these innovations in the medical sciences and healthcare was through competition. If you get rid of competition, what are you really left with? And so I don't know how much data there is to back that up, But you think financially and from an economics perspective, that actually makes some sense. And so the next thing is the unrealistic expectations of government. So this is something that you typically hear from the conservative side. So if the government can't manage X, Y, Z, fill in the blank, whatever you want to, how is the government going to be able to do healthcare? And so one of the arguments people make is that part of this is that the government will be able to set all these prices with pharmaceutical industries, other areas as well, but will it be able to do it in a quick manner? Can it do it so steeply to get to where we need to be? So maybe the government can do it eventually, but is that going to happen in 1 year, 5 years, 10 years? We actually don't know. So what we're anticipating to happen in terms of really driving down costs may not be that feasible in the short term. It may actually take a while to do. So we have to be a little realistic with our expectations for what the government's going to be able to do from a pure negotiating standpoint. And then the next thing is, now the government has to set up all this infrastructure to do Medicare for all. Granted, the Medicare already does have CMS Centers for Medicare and Medicaid, so that is there, but you're taking on a substantial number of more people. And so to be able to do that, think about all the services the government needs to do. Think about all the people that the government will have to hire to do this. And I think some people will argue, well, what happens to the other services that the federal government provides? What happens to education? What happens, excuse me, to other infrastructure that goes on in the government? So there's something that could be lost here as we try to do this massive overhaul of how we do healthcare. And so that is sort of the general. And then sort of on the demand side is, what about individual rights? This is almost sort of an ethical question. So, if I'm happy with my private insurance, my employer-sponsored insurance, why are you making me change? Why is Bernie Sanders saying that is gone in 4 years? Because there are some studies that say people are generally happy with their employer-sponsored coverage. So now this is saying fundamentally you are happy and we're moving you to something completely different. And what is the right of the individual to be able to have some say in that? And that's why you see some of these candidates coming up with more hybrid options where, Medicare for all if you want it. And I think it's to address that issue that some people actually, as much as we complain all the time, and we complain a lot about insurance companies, when you get down to it in some of these surveys, people actually are happy with what they have. So that's one issue, so individual rights. And then also this next issue is really increased demand in the system. So think about it now, you're going to have all these people now who are insured by Medicare for all. And so it means, in theory, a lot more people are going to use healthcare. So that's just going to really increase utilization across the board. And a subset of that utilization that people worry about is this concept called moral hazard. Has anyone ever heard of that? Economists talk about this a lot. So it's the idea if the people don't have to bear any cost of care, then they're just going to use much more. So in theory, it's going to drive up usage. So for example, if I'm home and I have a cough, before when I'm bearing some cost, so either my premiums or it's just the copay that I pay when I go into the doctor's office, no premium, no copay, I think I'm going to the doctor today. And it's not better the next day, I don't pay anything, so I'm going to go back. And so, again, this is a theoretical argument. So all those borderline decisions people make about going into the healthcare system or not, and things where they probably don't need to go into the system, they actually go in because they're not paying for anything. They're not experiencing or bearing any of the costs. So that's the whole idea of moral hazard. And then a different concept that people talk about is, well, now, if you're fully covered, you have less incentive to actually stay healthy. So in theory, say for example, someone may have diabetes, and whereas before if they had to bear the cost of coverage or they didn't have coverage before, they were really careful about controlling their diabetes. And now it's, again, sort of playing with this, now it's, well, I have coverage, so I don't really have to be as careful because if something happens, I definitely have a safety net. And my safety net is actually pretty good, so I'm not going to be as careful with regulating my sugars this month. Oh, I didn't pick up my meds. If something happens, I have the infrastructure to do it. And again, these are all theoretical, so some of you may not buy those arguments, but those are the arguments that people will definitely be making. So that's just about increased demand. And now the supply side. And so this is what people talk about a lot, is there going to be longer wait times. And this is what people always raise these urban myths about what happens in Canada. in terms of wait times for specialists, et cetera. And so, but this is something that we do have to think about. So if you put all these people into the system now, just by that, people are going to have to wait some. And with Medicare for All, the focus is going to be on preventive services, basic services, on emergency services. So where people will wait especially is for elective procedures and elective care, because that will not be the big priority. So when it comes to those situations, you're definitely going to wait. But even with some of the basic preventive care, some seeing the subspecialists, there is a concern that people definitely are going to wait. And just culturally, our society is not used to that. And again, as much as we complain, even with, I have to wait 2 weeks to get into a cardiologist, imagine what that wait time will be if with the Medicare for All and if people start to experience all those delays. And so now this whole concept of pay cuts, so people phrase this differently. It just means that, basically now if you get rid of private insurers, and as Ken said, they reimburse at a higher rate than Medicare. And so it's funny because in pediatrics we always say, oh, it'd be great to have Medicare rates because they're so much better than what we get in pediatrics with Medicaid. But for the average adult provider, Medicare is okay, but private insurance is a heck of a lot better to be getting overall. And a lot of these institutions, hospital, what they try to do is something called get an appropriate payer mix, where the sort of the ratio of what they get from private insurance relative to Medicare or Medicaid, and that's what keeps them financially viable. So now if it's all Medicare rates, are they financially viable in the same way? And I think some institutions say there's absolutely no way some of these institutions, hospitals, healthcare organizations can actually survive if they're totally reliant on Medicare. So if that's the case, it's going to be hard to survive. What will they in theory do? What they may do is start to contract services. They may start to contract the number of providers available to see people. All the sort of special things we may come to expect with our healthcare may sort of dwindle down because that's the way they have to sort of control costs relative to now getting lower reimbursement rates. So I think that's the concern. Not always salary per se, it's just now there's less money going into the system. The system has to find a way to survive. So what do, you cut providers, you cut staff, or you sort of contract in terms of the type of services you offer. So that is a concern. And some people say providers will have less incentive to provide quality care because again, you've sort of eroded this idea of competition is gone. And so now my incentive to provide quality care because I'm not competing along the same ways before, that I'm just not going to do as good of a job. And then people say there's going to be less money around for life-saving technologies. Getting back to this whole idea of competition is what breeds innovation. And so if you don't have much of that, you're going to lose some of the things that actually makes our healthcare system special. Okay, I'm almost done with this act. It's good. I'm working. So supply side issues in workforce. So just currently, you think about all the medical schools that are coming up nationally, we don't have enough healthcare providers to care for what we have already in our population. And so now if you flood the system with all these people who are all on Medicare for All, are we going to even have a greater shortage effectively because of the increase in people that are coming in? And then a downstream effect may be that working in this system, some providers may not have satisfaction. They may miss the things about, being able to see their patients in shorter intervals or being able to provide all the services they've been able to do historically. And that might have some people not want to stay in the healthcare industry in the ways they have previously. And then when you think about the next generation of people going into healthcare, seeing sort of the trends that are happening, hearing what people are talking about in terms of what their experience is like, they may not go into the healthcare system as they have previously. So there's this whole question on the supply side, will healthcare providers stay in the way they have just because of all these factors at play? So that is all I have.